We'd like to now invite Dr. Ronnie for his presentation. Thank you so much, Ravinjan sir. And it's really incredible to know the kind of thought process that goes into all these training programs, and people are really lucky. Today's students are really lucky to be learning under your guidance.
Volume does matter, as Abhi rightly said. The more the volume, the better for the surgeon. They can become better. But I also agree with Vijay, because having come from academia, to do 100 surgeries with all the protocols in place, what she had mentioned, you can be very good at it. Yeah, under good supervision, following all the parameters, recording each case, and having a look at each of your recordings in the evening when you go back. So I think all these matters.
So we'd like to now invite Dr. Ronnie sir. He's a senior consultant lecturer. Director.
So
He's a great person.
In person is sitting right there. So good morning and thank you for the invitation. So I'd just like to again reiterate what everybody has said. I was fortunate to train under many different people that I've had Ravi Thomas hold my hand and teach me how to suture. So that definitely somebody sitting next to you for 2 hours and helping you to do surgery makes a huge difference compared to somebody going from somewhere else and doing something else. So when you look at Oscar, so when you look at the Oscar assessment for trabeclectomy, these are the whole bunch of steps that you need to go through there. When you look at some of these, there are many of these that you actually learn during cataract surgery. So when you're looking at a combined cataract and glaucoma program, you don't really need to focus on these. So you need to focus somewhat on these things, and a little bit like the conjunctival incision, superior rectus, and the peripheral areolectomy. You can work into your cataract training program itself so that they get an idea of how to do it. So, just like Dr. Vijay said, the first step we do for everybody, even our glaucoma fellows who come, is to assess how good they are at cataract surgery. And this is a big challenge for us because now there are many programs which don't let you do any extra gaps. So you have somebody who's finished 3 years of training and has done a few trauma surgeries where they put a few corneal sutures and they've not done any other suture. And suturing is required for glaucoma surgery, for corneal surgery, for vitreoretinal surgery. So that's a big challenge that we are facing now. And of course, then we assess them how they are SSCS and FACO, and generally when they are doing their combined surgery, this is the pattern that we will do. We will teach them how to do combined surgery extra care. And with FACO, we have sort of, we don't really encourage them to do too many SSCS trabeclectomies because there's a lot of skill work being made at that time. So that's so just like Dr. Vijay said, we encourage rigorous practice on sponges, etc. the day before they operate. In fact, one of my colleagues insists that they send a WhatsApp video of them actually doing the process the day before because it improves their suturing skills the next day quite significantly. So we do a parallel approach in the sense we start the wet lab and at the same time we start with them steps of surgery. And the steps that we follow for trabeclectomy are the first 2 steps they will get would be a conjunctival therapy, the fibroblastin application, and then a flap creation. Then they go to creation of the ostium and PI, then flap closure, and only finally conjunctival closure because that's one which is most critical in terms of tissue handling and in terms of their suturing skills. So the first 2 they get initially and the bottom 3 later. So it would be nice if we had something like this, but it costs about 18,000 rupees to get one good modern eye to do a trabeclectomy suture. So what we do is use road size, and we have a 2 or 3 wet lab settings like this. And 2 things that we encourage is one, that the student either has somebody peeping in on the side when they initially operate, or we encourage them to take a video of what they're doing. They have an adapter there, they can put their cell phone and take a video, and they can go back and see what they are doing wrong or show it to us. When it comes to wet lab, there are 2 things that we teach them, and one is a paracentesis creation, which is a little difficult to do on the both sides because of how the softness. I put these videos there only to show you that the tissue handling is not quite what you see in a human eye. It's much softer, it's much spongier. So it's not quite the same as doing what you're doing, but they get a handle on how to do some of the steps. So here again, you're doing the ostium creation, and they learn how to suture the flap. And typically in one eye, they can go around and do maybe 6 to 7 procedures at one time. We teach them how to do releasable sutures also in both sides, and then they can come back and do it in bonus. The challenge, of course, is conjunctival closure. While there is a model available for this, this is again about 30,000 rupees. So conjunctival closure, we really don't have any good model, animal model in which you can practice this. And this is the biggest issues that we have with glaucoma surgery. We also train them in the steps of glaucoma implants, and they learn how to typically this would happen the same way. We have a few teaching valves, so they can learn how to prime the tube, they can learn how to place the tube, and again, it's not the same as doing it with MRI because these eyes are a little softer, and you will see that when they're placing the tube, it becomes a little difficult. Placing a plate is surprisingly easy because you can relieve the fluid and you and posteriorly. So they get a feel for pushing it in, but it's much easier to do it in this than in a human eye because of the orbit. So tube placement here again, because of the softness of the globe, it becomes a little difficult. And but here with one device, teaching device, you can teach 8 or 10 students. It's not a problem. Priming stays okay as long as they don't repeatedly cut the tube. You don't have a problem in doing that. And they do the same thing with us in theatre also. They learn how to prime. They learn how to place the tube. You do have training models like this, but again, very expensive. So a stepwise approach for tube training is in parallel to wet lab practice. They learn how to do one interaction sutures and conjunctival peritoneally with us. They learn how to prime the valve, and once they finish, they're comfortable with that. Then they look at giving them steps of the rest of the procedure. Post-op assessment, I think, is something that is not covered enough in glaucoma training program because that is really, really important. They're asked to see all the glaucoma post-ops that we operate, and they're asked to assess and make a plan as to what their patient needs. And for their own post-ops, the way they do it is they assess, they tell us a plan, show it to us, and we confirm what they need to do. So this happens for every single patient that they operate and every single post-operative visit that they come, so that by the time they leave, they know what they can manage. In terms of managing their post-op complications, they are allowed to do their injection file refuse, the releasable release, the Archimedes suture lysis. We encourage them to do their own needlings under supervision. If they have a necklace misdirection, we teach them how to do a gag and and we teach them how to do an AC reformation. Anything beyond that, in terms of conjunctival buttonhole management, choroidal drainage, eyebrows on the highlighter drainage, flat resurgery, and conjunctival spinal vascular, they only learn to observe because at this point in time, we don't think they are mature enough to benefit on their own. In terms of lasers, laser iridotomy, suture lysis, SLTs, diodes, and micropulse lasers, they are actively encouraged to do. The SLTs especially, we encourage them more and more to do because it gives them a better handle on common bonioscopic anatomy. So what next? And I think from SLT today, everybody's talking about the micro-invasive glaucoma surgery. So I looked at how much MIGS residency programs in the US give, and it's not much. So what you see is the middle number for MIGS is pretty small. It's about 2. So 50% of residency programs in glaucoma give 2 MIGS or less. Compare that with 2 trabeculectomies, 2 expressions, and 5 tuitions. So it's not a huge amount of data even there, but this is going to be a challenge for us coming forward with more and more MIGS coming into the picture. So basically you look at these MIGS sites and there is really currently no animal substitute for this. If you need to train them in MIGS, you will have to do it with this. And what we do try to teach them is, we give them good bonioscopy skills, we teach them how to do direct bonioscopy so that they are familiar with surgical bonioscopy, and we conduct a hands-on workshop using those type of models at least once during their program so that they've had some exposure to that. The challenge with mixed training is, of course, you cannot give them devices because of the cost and efficacy considerations, and the same challenges occur for implants too. Going forward, this is our challenge. Trabeculectomy rates are decreasing because we have more and more medications, and across all surgical programs in the world, the number of trabeculectomies postgraduates are getting a standalone outcome less. The number of combined surgeries has gone up a little bit. Implants are expensive, MIGS are even more expensive. So what we can try and do is we can give them the skill set to practice more complex procedures, and I think that is one thing that we have to focus on our programs on. Thank you.
Well, I just coming to get ready for the talk. A few questions for the expert panel. Like Arya sir had mentioned that with more and more experience, the complication rate comes down to around 1.3% or so. So is there something in trabeculectomy like that, any acceptable rate of complication? Yes, for the residents after they have done so many trabeculectomy.
I don't
Because
think
even
we-
published literature says it's around 25% for very
See, unlike cataract surgery, which is very, very predictable, and if you teach this way, you can get a predictable outcome. Whereas trabeculectomy is not predictable even in an experienced person, depending upon the clinical case and so many other things. So, our aim in teaching a good trabeculectomy is give them the good surgical skills as well as how to do a good trabeculectomy in a stepwise manner, like what Ronnie has said, and they have to learn how to manage the post-operative complication from the knowledge they acquired during the fellowship. Because even among our hands, a post-operative response varies very widely because it is a very unpredictable procedure, unfortunately so. And so this we don't have that kind of information to provide. In contrast to this, a tube has a little more predictability as far as the complications are concerned.
Would you recommend giving residents exposure to pediatric glaucoma surgeries during that?
I mean, they do observe and maybe few steps they do, but not in a full. And we encourage them to do a good thorough evaluation of the pediatric ophthalmologist, how we should. And we have a set protocol that includes the total evaluation of the child, that including the pachymetry and axial length, gonioscopy, how to measure the preference under sedation, and how to do the gonioscopy. So that it gives the skills to do the direct gonioscopy. And if at all we allow them to do few steps, not in a 10%.